Good morning, I'm Dr. Sriram, I'm a general physician. I welcome all of you today for this panel discussion on the practical difficulties faced by us in the management of extrapulmonary tuberculosis. To discuss this, we have with us three doctors to share their experiences and their insights about managing extrapulmonary TB. We have with us Dr. Syed Hizar, a chest physician.
Hello.
And we have with us Dr. Bhavani, neurologist. And we have with us Dr. Deena Nair, gynecologist.
Hello.
So let's start. The topic for today's discussion is on the practical difficulties faced by us in the management of extrapulmonary TB. All of you will agree with me that in terms of diagnosis and treatment of extrapulmonary TB, it is a challenging issue. So let's start with Dr. Syed. Dr. Syed, can you share your experience on the diagnostic issues faced in the management of extrapulmonary TB?
Yes, Dr. Sriram, I do agree with you. There are challenging issues in the diagnosis of extrapulmonary tuberculosis. It's extremely difficult to obtain bacteriological confirmation, and we normally go for a combination of clinical, radiological and histopathological findings for diagnosis. Extrapulmonary tuberculosis being paucibacillary, we do really require highly sensitive and specific tools for diagnosis. The existing tools such as smear and culture for AFP are not optimal for diagnosis, and that's why we do require new molecular diagnostic tools such as GeneXpert, MTB, RIF for maybe so important and may be used for diagnosis of extrapulmonary tuberculosis.
Okay, thank you, Dr. Syed. So Dr. Syed says GeneXpert is very useful in the diagnosis of extrapulmonary TB. So let's ask Dr. Bhavani. Dr. Bhavani, what is your experience in the diagnostic issues of extrapulmonary TB?
The new rapid diagnostic test, the GeneXpert, done on the CSF specimens in suspected cases of TB meningitis, offers a great help in the diagnosis of TB meningitis. Though a negative GeneXpert does not rule out TB meningitis, at least I can rely on the test if it is positive, along with other diagnostic methods and clinical features. Most importantly, I can get the results within 24 hours, and in addition, I will also know whether the mycobacterium is resistant to rifampicin or not. GeneXpert is really a game changer as far as TB diagnosis goes.
Okay, so Dr. Bhavani says GeneXpert is a game changer. So to add to my experience, so GeneXpert MTB RIF is also useful in the diagnosis of TB lymph node using FNAC specimens. Studies have shown that it has a sensitivity of around 80% and specificity of 90% against culture. This is very helpful in the diagnosis of extrapulmonary TB as it offers a better bacteriological proof compared to the FNAC specimens and the smear for AFB, as the positivity rate is very low in these diagnostic methods. And now let's move on to the other forms of extrapulmonary TB. Dr. Syed, what is your experience in the management of pleural effusion?
Well, unfortunately, we do not have any evidence to show that the GeneXpert MTB RIF is very reliable in pleural effusion, as the sensitivity is only about 46% against the culture for AFB. Basically, we rely on the radiological findings, then biochemical reports of pleural fluid and bacteriological tests like smear and culture for MTB. Moreover, one has to rule out the malignancy in pleural effusion. We had a patient who had a pleural effusion, and we were treating with anti-tubercular treatment, and subsequently we diagnosed malignancy when the pleural effusion did not resolve with ATT.
Okay. Thank you, Dr. Syed. Dr. Deena, can you share your experiences in the diagnostic issues of extrapulmonary TB as a gynecologist?
See, female infertility is a huge problem we encounter, and we do the investigations for TB while we do the workup for infertility. But the diagnosis of TB is very difficult, and we have to rely on tests like ultrasound, CT scan, and also some invasive tests like hysterosalpingogram and laparoscopy.
Okay, thank you. So we can see from the discussion that the diagnosis of extrapulmonary TB is still very challenging. So, though GeneXpert offers great help, we have to rely on other indirect methods for diagnosing extrapulmonary TB. Now, let's move on to the treatment of extrapulmonary tuberculosis. The issues in the treatment of extrapulmonary tuberculosis also poses a concern in terms of the regimen, the duration of treatment, when to stop treatment, the role of steroids, the role of surgery, how to assess the progress of treatment. So here, the duration of treatment in the absence of drug resistance is similar to pulmonary TB. So they are treated with 6 months of daily treatment, with first 2 months with rifampicin, isoniazid, ethambutol and pyrazinamide, and the continuation phase for 4 months with rifampicin, ethambutol and isoniazid. Only in case of TB of the central nervous system and skeletal system requires a long duration of treatment. Now let's ask Dr. Bhavani, what is the optimal duration for the treatment of extrapulmonary TB?
For TB meningitis and CNS tuberculosis, at least a 9-month duration of treatment is required, where we have a 2 months of intensive phase with 4 drugs, rifampicin, INH, pyrazinamide and ethambutol, followed by a continuation phase for 7 months of duration with rifampicin, INH and ethambutol. Alternatively, a 12-month regimen with the replacement of pyrazinamide for ethambutol is also suggested. As per the recent guidelines, streptomycin is replaced for ethambutol in the intensive phase.
So, what do you think is the optimal duration for the management of skeletal TB?
The recommendation is for a 2 months duration of 4 drugs with rifampicin, INH, ethambutol and pyrazinamide, and continuation phase with 3 drugs, rifampicin, INH and ethambutol. The continuation phase can be extended by 3 to 6 months depending on the patient's clinical prognosis.
Thank you, Dr. Paul. Let's ask Dr. Dina about the optimal duration for managing female genital TB.
The duration is the same as that of pulmonary TB, it's 6 months.
Okay. Let's now discuss the role of steroids in the management of extrapulmonary TB. Dr. Syed, what do you think is the role of steroids in the management of pleural effusion? Because it's also one of the common forms of extrapulmonary TB.
Initially, we were using steroids in the management of tuberculous pleural effusion. However, the recent evidence suggests that there is no benefit, and hence do not recommend steroids use in the management of tuberculous pleural effusion. However, the steroids are very much recommended for the management of pericardial effusion. The steroids have a major role in decreasing the constrictive pericarditis as well as minimizing the need of invasive surgery such as pericardectomy. We had a patient who had a massive pericardial effusion, and we treated him with ATT and steroids, and he just recovered without any sequelae.
Okay. Thank you. Dr. Bhavani, what is your experience in the role of steroids in the management of extrapulmonary TB?
Yeah, we give steroids for the management of TB meningitis for a period of 4 weeks initially, and we taper down it slowly. Studies have shown that steroids reduce the mortality in CNS TB, and it also plays a crucial component in the management of CNS TB also.
Okay. So it seems that steroids have a great role in the management of CNS TB and TB pericardial effusion and TB pericarditis. Dr. Bhavani, what is your opinion on the role of surgery in the management of skeletal TB or spinal TB?
Surgery plays an important role in the management of spinal TB when there is a pressure on the spinal cord, instability or neurological deficit. We had a patient who had a pot spine with paraplegia. She recovered well with anti-TB drugs and the surgical intervention. Surgery may also be indicated if a patient has a cold abscess also.
Okay. Dr. Syed, what is your opinion on the role of surgery in the management of extrapulmonary TB?
Surgery may be indicated in case of complications like gastrointestinal tuberculosis causes strictures which may lead to obstruction. Very well, the surgery will help them. We had a patient with constructive pericarditis, and we went for a pericardectomy in that patient, and it was a successful case for treatment.
Dr. Bani, what do you think is the role of surgery in managing neuro-TB?
In neuro-TB, hydrocephalus may be a complication of TB meningitis which has to be managed by a ventriculoperitoneal shunt.
So, Dr. Dina, what do you think is the role of surgery in the management of extrapulmonary TB?
Yeah. Surgery is not always indicated in genital TB. It may be required in case of a large residual tubo-ovarian abscesses. Surgery is actually associated with higher complication rates as there are a lot of adhesions in case of genital TB.
It is clear from our discussions that surgical interventions are important in the management of complications or sequelae of extrapulmonary TB. This necessitates the importance of early diagnosis and treatment of extrapulmonary TB. Of course, for obtaining any form of biopsy or specimen of extrapulmonary TB, surgery is required. Another challenge we face in the management of extrapulmonary TB is when to declare cure and when to stop treatment in the patient. In case of sputum positive pulmonary TB, we can declare cure at the end of 6 months if the patient has become smear negative. It is difficult to obtain microbiological confirmation in case of extrapulmonary TB. So that poses a challenge in declaring cure and stopping treatment. So let's ask Dr. Syed, how does he stops treatment in case of extrapulmonary TB?
We basically have to rely on clinical progress and radiological improvement in deciding the treatment success in any patient.
Dr. Bhavani, what is your approach to stopping treatment for extrapulmonary TB?
Yes, we have to monitor the patients closely for their clinical progress. However, we are in a dilemma regarding stopping treatment when the patient has not fully recovered and he's got residual neurological deficit, and it is also difficult to convince the patient for stopping treatment when he don't feel that he has not fully recovered.
Dr. Syed, what do you want to say about this issue?
I agree with her. It is similar to the case scenario where you treat pulmonary tuberculosis and do see residual lesions in the chest X-ray with smear or culture negative. However, disease sequelae is not the basis for extending the treatment, whether it is a pulmonary or an extrapulmonary tuberculosis. Residual small fibrosed lymph nodes less than 1 centimeter which persist even after the 6 months of treatment, they do persist and they really do not require any extension of treatment. If at all you extend the treatment, they may not be benefiting. So this whole thing need to be explained to the patient in detail.
Close follow-up of the patients clinically, radiologically and microbiological confirmation wherever possible is essential to monitor treatment progress. Worsening of symptoms or appearance of new symptoms is a matter of concern. It is important to decide when the patient is not responding to treatment. It is important that we see that the patient is adhering to treatment before he is declared as failure. Sometimes we forget to do this. So how do we understand non-response to treatment? Dr. Syed, how do we understand non-response to treatment in case of extrapulmonary TB?
We have to be extremely cautious in declaring failure to the treatment, and we must remember the aspects of IRIS, that is immune reconstitution inflammatory syndrome in these patients.
Dr. Bhavani, what is your experience of IRIS?
Yes, iris or paradoxical reaction occurs within 3 months of treatment initiation, where the patient has initial improvement followed by worsening of the lesions or symptoms, or some patients develop new lesions or symptoms. I have come across this in the management of brain tuberculoma, where we had a patient where we started her on anti-TB treatment. After 2.5 months of treatment, she developed new seizures and an repeat MRI showed new lesions in her brain. We were thinking of some possible reasons like treatment failure, drug resistance, and IRIS was also considered as one of the possible diagnoses. We continued her on treatment and the patient recovered well, and her symptoms also regressed subsequently.
So, Dr. Syed, what is your experience with IRIS?
This is particularly very common in the management of lymph node tuberculosis, where you see increase in size of existing nodes or fresh nodes appearing during the initial phase of treatment. It is a matter of concern for both the treating physician as well as the patient. However, this must not be a point to decide on the treatment failure or to change the treatment regimen. One must continue the treatment so that these lymph nodes do resolve. In cases where the lymph nodes do not resolve, you certainly need to reinvestigate and find out the cause of drug resistance or any other alternate diagnosis.
Identification and management of paradoxical reaction adds to the many challenges of managing extrapulmonary tuberculosis. Drug resistance in extrapulmonary TB, if diagnosed, has to be managed in a similar way as in pulmonary tuberculosis. So, ladies and gentlemen, from all these discussions, we understood that there are several gaps in the knowledge about the management of extrapulmonary tuberculosis, and research is warranted, especially in the diagnosis, treatment, and monitoring progress to treatment. On this note, we come to the end of this panel discussion on the practical difficulties in the management of extrapulmonary tuberculosis. I thank all the experts for their valuable insights and sharing their experiences, and we expect that this panel discussion will be very useful in the management of extrapulmonary tuberculosis patients in your practice. Thank you.
Thank you.
Thank you.
Thank you.